Everybody. My name's Ed Pavlik. I'm in Lexington, Kentucky. And my colleague today is
Frank Lawton from London in the United Kingdom.
great. Well, Frank, I learned something interesting on the BBC the other morning, and that's that a banana sold at Sotheby's for $6.2 million.
Yeah, yeah.
Maybe we should go halvesies on a bunch of bananas listed at Sotheby's and maybe make 30 million. And the proceeds going to ovarian cancer research. What do you think?
I think the problem, Ed, is that the banana is unique. If we flood the market with bananas, the price will drop. You've got to be careful. You've got to have your USP should be a single banana taped to a piece of paper. If you have too many bananas, that we don't want to flood the market. We have to keep it mean, lean and mean.
I understand. Oh, well, that's too bad. I thought maybe
Yeah,
we could
yeah,
do something here.
yeah.
Today we're going to consider a question. What do physicians feel about how long women with long-term ovarian cancer should be treated with the PARP inhibitors? Answer to this question is approached in a paper titled How Long is Long Enough? An international survey exploring practice variations on the recommended duration of maintenance therapy with PARP inhibitors in patients with platinum-sensitive recurrent ovarian cancer and long-term outcomes. The paper was recently published in the International Journal of Gynecologic Cancer. And we're going to explore this both with human and artificial intelligence. Frank, give us your human insights into this paper.
Okay, well, I think the role of maintenance PARP inhibitors is talking about making ovarian cancer now becoming a chronic disease, a disease that's manageable over the long term. And the PARP inhibitors seem to be the drug of choice for this sort of treatment. PARP inhibitors are known to have myeloproliferative problems, and indeed long-term chemotherapy for ovarian cancer and marrow suppression is not new. I remember Alain Dembo from Toronto telling about this many, many years ago when they were using long-term low-dose chlorambucil. So the myeloproliferative effect of chemotherapy, any type of chemotherapy, is well known. This is an unusual study because essentially the authors spend a lot of time talking about the so-called pivotal studies that compared PARP inhibitors versus placebos, giving over with a proportion of patients being treated over 5 years. The data are not particularly strong. Only 3 of 6 pivotal studies actually give any data on outcome of PARP inhibitor treatment over 5 years. But something like a quarter, between a fifth and a quarter of patients seem to be on it for over 5 years. And they look at the myeloproliferative effect, and essentially the effect is not particularly high over 5 years. It goes from about 1.5% to about 8%. And interestingly, because they're all placebo-controlled studies, there's even myelosuppression in the placebo arm between 0.8 and 4%. Interestingly, it's the olaparib study that is this seems to be the outlier, 8.2% myelosuppression after 5 years versus 4% in the placebo. I don't know about the explanation of a placebo giving myelosuppression. Anyway, this study has asked 100 and odd or 200 and odd oncologists, medical oncologists, gynecological oncologists, about their recommendations for long-term or for greater than 5-year experience in treatment. Interestingly, out of the 105 responses that are full, only 7 came from the United States, which surprises me. The majority of the cases came from either Europe or from Oceania, and only 7 out of 195 responders were US-based, which did surprise me a little bit. So essentially, the authors asked these people, did they have clinical guidelines for the length of treatment for PARP inhibitors? And 73% of the responders said that their centers did not have clinical guidelines. Now, obviously, the patient data are available. The FDA data is available there. So it's not that the data are not available. It's just that for some reason, nearly 3/4 of centers don't have recommendations as to how long PARP inhibitors should be given. If you look at the data, those with recommendations nearly half of them recommend treatment between 1 and 3 years, whereas if you don't have recommendations, that's about 22%. Interestingly, in the group that does have the recommendations, 4.9% want to say we should be given for less than a year, and that is not in the recommendations by any of the regulatory bodies at all. So why 5% of patients should be stopped being given PARP inhibitors after a year, I don't understand. Going on at 4 to 5 years, those that have got the recommendations, they essentially none, whereas those that don't have the guidelines, there's another 20-odd% continue. And if you look at indefinite treatment, indefinite meaning until progression or toxicity, we've got nearly 54% of patients in situations where there is a protocol and 48% where there isn't. So not a lot of difference there.
And that's
Except
not statistically significant either.
I don't think, yeah, it's not significant at all. No, it's just, I'm just surprised that those that have got essentially, there doesn't seem to be any particular difference really in the length of time that these centers think that PARP inhibitors should be given. I think essentially, this is looking at just one particular aspect of what happens. Do patients on PARP inhibitors suffer myeloproliferative disorders? And what they haven't recorded, of course, is the previous treatment. Are they all on platinum? Have they had Taxol? Have they had sort of immune responders? Is there some recall bias? Other people that respond and say, yes, I've had patients with myeloproliferative disorders, whereas people that haven't responded haven't had patients with myeloproliferative disorders. Also, there's no recording of the histology, the BRCA in part of the studies. So we don't know how many of these patients were BRCA carriers. We don't know anything about dose modification during treatment. We're assuming that at 5 years, they've all had exactly the same amount of treatment, but that's not the case. I think essentially that this is a review of trial data with a bit of an audit attached to it. And I don't think, well, let me give you the final thing. There's an adage that says, if a newspaper headline, or indeed any headline, has a question mark at the end of it, you know that the answer is no. And this one says, how long is long enough? And I don't think this paper starts at all in saying how long is long enough. It doesn't give enough data on what the patients were and what sort of treatment that they had. So I think, sadly, that although it's an interesting paper, and I think as the authors say, there's going to be a lot more data generated. At the moment, I don't think it really gives us any insight whatsoever into the duration of treatment for PARP inhibitors.
Yeah, I agree totally, Frank. I think it was basically sort of an attempt to maybe get the momentum for the next step study where one can actually determine the answer to that question. I will point out, as you well know, that there's an expense question that's associated with all this, and at least in the States, we're talking about a monthly cost of about $20,000 of taking the PARP inhibitors, and now someone's going to pay for that. Now the patient may pay as little as 5 or 10%. Which is, 5,000, basically still expensive. But after 5 years, the cost really adds up so that it's going to keep maybe $1.2 million to keep up with treatment over a 5-year period. And the U.S. median income is $193,000. That's the the median net worth of someone in the States. So we're talking about how that compares to the cost, and their net worth is about 16% of the cost over that period of time. And now that's the average or total median, but if you just look at the top 10%, that net value, net worth is around $2.5 million. And so we're talking about paying, for the treatment, half of your net worth if you're in the top earner category.
Yeah.
And so, when to stop is sort of when you go bankrupt. When you run out of money is, one comment's there. And I think that's a discussion that caregivers don't want to get into.
Of course not. I think the idea that you should give PARP inhibitors until toxicity or progression, or you can't afford it anymore, or the country can't afford it anymore. However the care is funded, they don't put that into the mix really. Perhaps they should.
Well, let me add a final comment. We did submit this to both Gemini and to Copilot with the idea was critically analyze the paper. And Gemini really did a very bad job. They did not recognize that the paper was about exceptional responders to chemotherapy. That whole point was missed. And they also missed the point that this was the viewpoint of the providers rather than an actual trial. Now, Copilot did a whole lot better. They were spot on. They had the numbers that were in the article, and they had the conclusions that you and I have come to. So, in one sense, again, there's a big difference between the two major generative AIs that can be fed the question about these papers and their answer.
Very interesting, isn't it?
It sure is.
Perhaps they better stick with us for a while.
Yeah, I think it's not bad to be human. Well, Frank, we've done it again.
Yep.
We finished another GYN Garage, and I look forward to doing this again with you next month.
Look forward to it. See you soon. Bye now. Bye bye.